Hello, I'm Norman Swan. Welcome to this asthma update. There are more than 2 million Australians living with asthma, and one of the biggest changes in treatment over the last few years has been the introduction of combination therapies. And that's what tonight's programme is about. It's sponsored by the National Asthma Council Australia with unrestricted funding from AstraZeneca. And we're coming to you live across Australia through the Rural Health Education Foundation's satellite network. As usual, there are a number of useful resources available on the Rural Health Education Foundation's website. It's at rhef.com.au. Now, let's meet our panel. Matthew Peters is an Associate Professor in Respiratory Medicine at the University of Sydney and a respiratory physician at Concomitant Hospital in Sydney. Welcome, Matthew.
Good evening.
Clive Tucker is a general practitioner from rural southeast Queensland, whose past experiences include conducting respiratory clinics with the South African Army. Welcome, Clive.
Thanks very much.
So many wheezing conscripts are there in the South African Army?
Millions.
Many? Right. Stephen Hughes is a community pharmacist from Petersham in Sydney. Welcome, Stephen.
Hey, Norman.
Stephen's an old hand at these programmes to do with asthma. And Judy Wicking is an asthma educator running clinics in general practice. And she's also a project officer with the National Asthma Council Australia. Welcome, Judy.
Thank you.
And welcome to you all. Matthew, what are we talking about here when we talk about combination therapy?
We're talking about some of the more modern asthma treatments and combine a long-acting bronchodilator or a long-acting Ventolin-type preparation in conjunction with a very effective inhaled corticosteroid medication. And for patients with moderate to severe asthma, they really represent state-of-the-art maintenance asthma treatment.
What's the evidence supporting them?
Well, if you have asthma beyond mild, that is, you're on good low-dose treatment with inhaled steroid and your asthma is not optimally controlled, then adding a long-acting bronchodilator is a very effective way to improve symptoms and over the longer term achieve good asthma control with less inhaled steroid delivery. So yeah, improved lung function, improved nighttime sleepiness, reduced exacerbations is what we want for our patients.
Because you can't use long-acting by themselves.
Absolutely not. Clear, unequivocal evidence that just adding long-acting bronchodilator to Ventolin or another without inhaled steroids is deleterious for asthma and should never be done.
And we're essentially talking about two preparations in Australia.
Yeah, in the Australian context we have two preparations. There's the salmeterol fluticasone combination marketed as Seretide, and in addition we have budesonide formoterol, which is marketed as Symbicort. And
both with similar effectiveness?
They are similarly effective when used as maintenance treatment for asthma, but as we'll discuss later on, formoterol, which is the long-acting bronchodilator component of Symbicort, is different from salmeterol in as much as it acts quickly. It acts as quickly as a bronchodilator as salbutamol would, so it gives us the opportunity to use that intermittently for symptom relief as well as maintenance.
But there are suggestions we're overusing combination therapy in Australia.
I think we certainly have overused inhaled steroids and the sort of efficiency dividend.
Meaning too high a dose?
Yeah, too high a dose. Well, one thing is too many patients, different discussion, but certainly you would have predicted with the wide use of long-acting bronchodilator that our inhaled steroid doses would have gone down, and they disappointingly have not gone down much, if at all. So we haven't got that sort of modern political parlance of efficiency dividend. So I think that we have been through a phase of using too much inhaled steroid. We need to change that. But we also need to define the correct patient to use these very good treatments on, and other patients for whom lesser treatments would be just as effective. And of course we have to be careful the patient has actually got asthma before we start firing these things at them. And
what would be the metric that a GP could use for him or herself to know whether or not the right proportion of his or her patients are on combination therapy?
I think a GP serving a rural community should have maybe a quarter of their patients that, well, there'll be some patients they don't know have asthma, that's just the reality. Some patients will truly just have intermittent wheeze, they're a small number. And you would estimate that probably 30 to 40% of asthmatic patients should just be controlled on inhaled steroids alone.
So they're going to be mild?
They'll be mild by definition. My definition of mild is you give them inhaled steroid and everybody's happy with asthma control. If you give them inhaled steroid, they take it, they know how to use it, and they're not well controlled, they go beyond mild, that's where combinations kick in.
So if just under half of your patients are not on inhaled corticosteroids and most of your patients are on combination therapy, you're spreading around the combination therapy too much?
I think that perhaps on reflection some of those patients could be as well controlled just with inhaled steroids alone.
And save our taxpayers money?
Save everybody. I think we have to be efficient across the whole drug treatment, disease diagnosis and drug treatment spectrum for sure.
So what's your percentage, Clive? Are you doing the right thing?
My demographic, I think, is slightly different to what Matthew sees. I work in a rural practice outside of Ipswich, and a large proportion of my patients are rural, and I think many of my patients are not as ill as the patient that Matthew sees. So I would say that...
So you'd have an even higher proportion just on inhaled corticosteroids?
A little bit higher, probably about 40% maybe. Then obviously a lot of patients are just on beta-2 agonists by themselves, and then an increasing proportion are on combination therapy.
So really, that's the real measure for yourself. It should not be the majority of your practice being on combination therapy.
I would agree. However, I really believe that combination therapy has made a huge difference to the management of asthma. It's not that long ago that I graduated, 1989, and from 1989 to now, the number of people presenting and lying around emergency departments with that nebulizer going and getting cortisone squirted into them, that number's dropped hugely. And even in general practice, it's rare that we see severe exacerbations presenting at the surgery, whereas some 15 years ago we saw a lot more. And I think that's largely credit to good drugs with good inhaler devices and combination therapy that's made a big difference.
What's your impression, Judy?
Certainly the control of asthma, as we see, there's not the same presentations at general practice or in hospitals or emergency visits in ambulance of people with asthma. But if we read some of the more recent reports, the Australian Centre for Asthma Monitoring report, I think we've still got a long way to ensure that our patients have been managed appropriately. There's still a lot of patients out there that perhaps could be managed better.
So both overtreated and undertreated?
Both.
We still have an issue, Matthew, about diagnosis, getting the diagnosis right?
I think that you can't begin to treat any disease without having sort of sat down and taken a good history and then performed a relevant examination. And in this case, I think we should be trying as much as possible to prove asthma physiologically and to prove to ourselves and to our patients that the symptoms that they're troubled by are actually asthma symptoms, particularly when you're getting to really second line, very effective, but second line treatment. That is, I've got a diagnosis, I've given something, it hasn't worked, you know.
So before you would even think of combination therapy?
Oh, well, I think so. I think we just know, and the history, Clive is right and Judy's right, you know, we've got a spectrum of very, very good asthma treatments, and if you walk back 30 years with these treatments, you would have been considered a miracle worker. They are so effective compared with the late 60s when we had people on 20 milligrams of prednisone, you know, just to keep them out of hospital. I mean, this is a revolutionary change. Very effective treatments. When very effective treatments don't work, we need to go back into our systems and our system of diagnosis, our system of assessment.
So spirometry in every patient?
Oh, spirometry, if you've got spirometry, sure. That's one thing. That's at the diagnostic level, but systems of diagnosis, systems of care, and I think the things that Judy and Clive were saying about reduction in exacerbations, yes, certainly we've got better drugs, but in this country we've been with everybody leading the world, and perhaps only matched by the Canadians in having a comprehensive system of care and public education. That is, the systems of care for people with asthma have improved so much, and the drugs are good and the systems of care are better.
Often the first place of view is pharmacists. Do you feel pharmacists are engaged in this enough, Stephen?
I think they are. I guess an issue I see is that we do spend a lot of time with the short-acting beta agonists as pharmacists. We're the gatekeepers of it to the majority of the population. A lot of that time we could actually add to helping people on inhaled corticosteroids as well and combination therapy, because there's still a lot of people out there that are getting their prescription, getting their 5 repeats, potentially not taking it regularly, potentially not taking it twice a day, which is the most effective, potentially still on a high dose that they don't need to be on the potent dose. They could potentially be withdrawn down. And we really need to be looking at these patients, looking at our script records and saying, look, this person hasn't come in for a couple of months on their prescription. What are they doing with it? Let's have a talk to them. What are you doing? Is there an issue with it? Is it a cost issue? Is it you're worried about the high doses of steroids issue? All these sort of things can be looked at, but yeah, we need to sort of be.
And there is considerable out of pocket, isn't there?
There's no doubt about that. $31 a month is a considerable amount.
Plus your ventilator.
Plus the short-acting beta agonist as well, yeah, definitely.
We've got 3 or 4, a couple of case studies for you anyway. I'm just lost sight with how many we've got for you, but just stick with us and we'll give you them all. Our first case study tonight is Adam, who's 9. He's very active. He plays football, cricket and swims 3 or 4 times a week. He was diagnosed a while ago with mild asthma, and since he was about 6, he's been trucking along at about 2 or 3 episodes of wheezing a month, and he manages quite well, his symptoms quite well with salbutamol. In the last couple of months, he's noticed an increase in his symptoms and seems to be getting wheezy almost every day of the week. Clive is your patient.
Adam's interesting in that you can see he's been exacerbating for the last 2 months where his asthma is getting worse. So we need to ask ourselves a few questions. Firstly, as Matthew said, has he got asthma? We've decided, yes, that he probably does have asthma.
But how have you decided that? Just because he's got a bit of wheezing?
Well, he's 9, so he should actually tolerate a spirometry. He should be able to give us a reasonable flow curves. His history over the past few years, where he has actually responded well to salbutamol, is strongly suggestive. Doesn't mention whether he's atopic in any way. But I think too, we need to try and establish just how much inroad is his actually asthma making to his life. You know, is he able to exercise? How much does he cough? Does he wheeze? Is he short of breath? Is he waking up at night? Or is he just somebody who is very aware of even remote breathlessness? So we need to actually establish just how severe his asthma is. And once we understand that, we need to have a look at how he's using the medication that he is using. Is his technique all right? Is he using spacer devices? And if he's doing all of that, then we've got to look further and say, well, how better can we manage him?
So how better can you manage him?
Well, he's 9, so as he stands, he needs to be on a decent anti-inflammatory, and inhaled corticosteroid would be a good choice.
But hold on a second. In the bad old days, you just said no inhaled corticosteroids is first line. You should go for chromoglycate.
I think
avoids stunted growth, avoids cataracts later in life. Why not?
Growth. Well, let's look at some of the arguments. There is still a strong steroid phobia, and certainly there are options. Yes, chromoglycate is an option. It's probably worth looking at. There's also leukotriene receptor antagonists, so that's another possibility. But you know, current best treatment is actually inhaled corticosteroids. Low doses delivered to the right place with a spacer device. They're good medications.
So what would you start them on if you were going for inhaled corticosteroids?
Well, something like budesonide or fluticasone. Probably initially starting them on either 50 or 100 micrograms twice a day as a starting point, and keeping him on a diary, using an asthma symptoms diary where we look at his symptoms and look at his beta-2 agonist use. And often that's very empowering, actually get him involved in his management of his own disease. And we've got a chance of at least finding out better how he's responding.
And how long would you wait for an effect of the corticosteroids?
I think a reasonable period is 3 weeks, but we obviously, with asthma being a dangerous disease, people still die from it, need to keep an open door. If there's any worsening, there has to be an asthma action plan in place that he would either present to you or present to the hospital or get hold of further medical advice.
What do you think, Judy?
Certainly engaging the parents in the discussion about the medication and device use, ensuring that there's an adequate and appropriate device for the child, and that the parents involved in that decision making, 9 years old, parents still sort of should be keeping a pretty close tab on what's going on at home as far as medications. Yeah, it concerns me when a child of that age can't play their sport without any symptoms. You'd be wanting to just be very sure and differentiate between normal huff and puff and true asthma, and again, perhaps how long does it take for the symptoms to resolve after their sport, and response to treatment, of course.
So Matthew, I mean, the Blue Mountains Eye study, albeit these are people over 65, has shown that cataract, the risk of cataract is significant on inhaled corticosteroids. Shouldn't we still be just a little bit careful about inhaled corticosteroids, particularly starting in a child?
Look, even at this stage, we've really only got 25, 30 years of experience of using these inhaled steroids, and we're talking about Adam at 9, unless we get a major therapeutic advance, perhaps having 60, 70 or 80 years of these drugs. So I think the obligation on us then is to make the right diagnosis, use the right treatment in the right patients, and to work towards using the minimal effective dose that achieves the aims of treatment. And I have a very pragmatic approach that I talk to patients, and I say just to liken it to a Mars bar. You know, a Mars a day helps you work, rest and play. So if work is not an issue for Adam, but he doesn't miss school, he doesn't have nighttime disruption from cough or wheeze, and he's able to participate in his sport without being restricted by asthma. So if we achieve those goals of treatment with the lowest dose of inhaled steroid possible, then we will, in the future, have done everything to minimise those risks which may be important, and indeed ones we don't know about yet because we haven't studied them for long enough.
So is there still an argument for aim high, back titrate? Is there any evidence supporting that, or you should just go in with what you think is going to be the right dose for him and just stick with that?
I think there's pretty strong evidence that you end up at the same place, you've just followed two different routes. So start
So
low,
if you think 50 is going to be all right, start low.
Start low, edge up, or start high, edge down, you end up at the same place. But we have to have faith in ourselves, and if we start high, come down, then that's what we have to do. Unfortunately, in Australia, we've developed a tradition of starting high and not going down.
And staying high, yeah. And that's where, you know, the people perhaps get into problems. And what are the statistics on adherence, Matthew?
Well, we know that adherence is not what we would like it to be, and there's all sorts of reasons. People living with asthma love to adjust their treatment in accordance with the broad patterns of their asthma. So we know in our routine, when they feel well, they drop off their treatment a bit, they get unwell and they pump it up again. That's one issue. There is a steroid phobia has been alluded to, and we have to acknowledge that. And finally, some very interesting data from the Australian Centre for Asthma Monitoring, and something that we as doctors and other clinicians working with asthma need to be mindful of it, and that is that economics do come into treatment adherence, even in a wealthy country like Australia.
Because people can't afford the co-payment.
Some people can't afford it, and there is greater adherence to asthma treatments in those who are concessionary beneficiaries under the PBS versus those that are paying the full price. So people, we acknowledge hardship out there in the community. People are making choices, and some of those choices involve taking a treatment or not taking a treatment. So, you know, you can't compel someone to spend money they don't have, but at least you've got to be mindful of that in your clinical practice when you're trying to determine why someone hasn't got better.
A question coming in from a general practitioner in New South Wales, the country of New South Wales. To what extent is tapering of oral steroids necessary when they've only been used for a few days, say, 10 days, Matthew?
Most people who have acute asthma should not be on oral steroids long enough to worry about tapering. So in kids, you're using it for 2 or 3 days, no taper. Most adults are better in 5 to 7 days, no taper. And really, even if you're getting out to 10 to 14 days, you don't really need to taper at that point. Okay. And tapering is very complex. You know, remember the historical things, you know, you're 2 days on 40, one on 37.5, one on 25, and you've got 25 milligram tablets, 5 milligram tablets, takes 10 minutes for the poor pharmacist to dispense them all. I mean, I'd just go in 25 milligram tablets, they take a full one or a half of one, and just make it nice and simple. Yeah. Make it nice and simple. The normal people out there, you know, who are you know,
as long as you have simplify arthritis, you're fine.
Yeah. Well, different, yeah.
Now, Clive, so what are the indications then? So just to summarise to where we are now, from what I've heard, is that most people in your practice are going to have mild asthma, therefore you should not have most of your patients on combination therapy. Inhaled corticosteroids are the first line therapy when you've got somebody who's getting frequent asthma. But then the question is, who gets combination therapy?
Well, by definition, the PBS states that moderate persistent asthmatics who are not adequately controlled on good dose of inhaled corticosteroids themselves, they don't state exactly how much, those patients are good candidates for combination therapy. And once we've established that, and because fortunately in general practice we have fairly easy, even though we're pretty busy, we do have it's a luxury of frequent follow-up, and you know within the community, and we're accessible. Those people, if we've established that yes, they do indeed meet the criteria, not only meet the criteria, but they would actually benefit, then those are the patients we would consider either to give them this the salmeterol combination or the fluticasone combination, or the Symbicort combination. And the choice of patient and the regimen is really, it's practitioner dependent, And I think we need to find a strategy
Hold on a
that
second.
works for us.
Practitioner, who cares about the practitioner? Isn't it patient dependent here? That's a sort of surprising statement.
In fairness, both products are excellent products, and it's really your rationale of treatment and what would suit that patient best. Absolutely.
So it's patient-centred rather than
Sure.
practitioner-centred. Stephen, tell us a little bit about these medications.
Okay, well, we'll start from the beginning. It's a stepped approach to asthma management. For intermittent or infrequent asthma, we're only looking at a short-acting beta agonist only. That's all they need. Moving on to more persistent asthma, mild persistent asthma, as we've stated before, a low-dose inhaled corticosteroid is the treatment, the best treatment going around. Okay, and when I talk about a low dose, we're looking at sort of 100 to 200 of fluticasone or beclomethasone, or 200 to 400 of budesonide. And it is a low dose compared to what often we're seeing around. So that's for mild asthma. Going on to that, to moderate persistent asthma, the next step is to add a long-acting beta agonist. Now, as I've alluded to before, studies have shown that that's actually more effective than doubling the doses of the inhaled corticosteroid alone. So you're having less symptoms, less exacerbations, and better lung function.
So it's exactly what Clive was talking about there, which is you're at the situation where you're giving a reasonable dose, and rather than being tempted to go up to 1,000 micrograms a day, that's the time to start thinking about your
Let's add the long-acting beta agonist, and that's proven to be more effective. Okay, so there's two types of that, as we've alluded to
and
before.
presumably, sorry, and this is something we didn't talk about, Clive, you've got somebody on who you might have on uncomfortably high doses of inhaled corticosteroids. Presumably going on to combination therapy gives you the opportunity of lowering your steroid dose.
Exactly.
The principle obviously stands as where we'd like to use as little medication as possible, but as much as the patient needs.
Sorry, I interrupted.
So it definitely gives that an option to lower the doses, which could be handy with a lot of patients we see. So there's the two options. There's the ephemerol-based one or the salmeterol-based one. The salmeterol, while being a beta agonist, takes 15 to 20 minutes to work. So we're only using that for maintenance therapy. Both of them we're using for maintenance therapy, but the salmeterol only for maintenance therapy. Okay, so it's a twice daily dosage using the same inhaled corticosteroid dosage as you were using before, adding the long-acting beta agonist. Symbicort is a different one. It's a special one. The ephemerol actually has a 1 to 3 minute onset of action as a bronchodilator. So it can be used in two different ways. As maintenance therapy, still the twice daily dosage, but there's also another way we use the Symbicort as the only inhaler that you have, so you don't have a short-acting beta agonist, and you use it for PRN symptom relief as well. And that's proven to be fairly effective as well.
So, Matthew, I don't see how that can't be toxic. I mean, you can't have it both ways. A long-acting beta agonist, which obviously fills up your receptor sites, and you're taking it as a reliever. Surely this is a recipe for danger.
No, it doesn't work out that way, and this is one of the most interesting things about this new paradigm, the paradigm of using Symbicort for both maintenance and reliever. In fact, if you compare, Symbicort comparison is the easiest one to do. So if you compare a group of patients with moderate asthma who use 2 Symbicorts morning and evening, plus terbutaline or Bricanyl, versus those who use 1 Symbicort morning and evening plus extra Symbicort, in the end, the ones who are using it for both maintenance and relief use 25% less Symbicort overall. Their lung function is just as good, their symptoms are just as good, and they experience a very marked reduction in both severe exacerbations and the number of days they take oral steroids. So it's a sort of a less is more scenario.
And have they been followed for toxicity? Because we've been caught out with this before.
Well, there's no reason, so far as we know, to worry about toxicity because they're actually using less Symbicort. They're using less formoterol.
I see.
With this new paradigm, they're actually using less Symbicort. So the health economics here is a no-brainer. Less drug, better outcome. By allowing the patients to use both some maintenance, which is critical, and using their Symbicort, titrating their asthma treatment by this one simple thing, and that is when you feel wheezy, use it. That's not too hard. What it means is that we can self-adjust the treatment for when they really need it.
I should actually add that it's actually only the bottom 2 strengths of the Symbicort and not the top strengths. It's the 106 or the 206, but not the 412. And it's only for adults and children over 12 years of age.
So it's off-label if you prescribe it for under 12-year-old. So Adam, if you were to think of a combination therapy for Adam, it's this serotype product, salmeterol product.
The maintenance and reliever therapy wouldn't be that. No.
Do you often give children combination therapy, Clive?
I wouldn't say often, but yes, I do have a cross-section of children that do very well on it, especially the night wakers, many of the exercise-induced asthmatics who have ongoing persistent asthma. And they do well. I don't have a huge number of patients, but yes, in the under 12s, the Serotype is a great product.
Judy, you've got some concerns about combination therapy from what you see around the place.
I guess the concern is just appropriate use mainly, and also for the patient's perspective is understanding the roles of the medication and how they work. I still certainly see there's some confusion out there. Some patients will be using their salmeterol, for example, as a reliever and using their combination therapy, using their salmeterol as a preventer, using their combination therapy as a reliever, and I've seen that. And so there is still some confusion out there about the roles of the medication. So I think to engage the patient in not just providing some information, but ensuring that they understand the importance of taking a reliever.
And what about appropriate indications?
Well, yes, I guess sometimes I feel a bit concerned when I see the prescription of combination therapies for viral-induced exacerbations of asthma symptoms, and that's of concern, I suppose. So the patient just presents with a viral infection and they've got those asthma symptoms, wheeze, cough, night waking, etc. They're prescribed combination therapy. So that's of concern. It's not following the PBS guidelines as what Clive has mentioned.
So Matthew, let's just go back to the situation where you're not responding as well to the inhaled corticosteroids. Yep. Automatic switch to combination therapy, or should you have another think?
No, automatic switch on. And the switch on is, does the patient have asthma? Are the symptoms concerning the patient and therefore me related to their asthma? Are they adherent to treatment, and we have to use our clinical analysis to issues around adherence, and we have to.
So don't just accept it as a failure.
No, but we have to engage the patients. I mean, there's reasons why they're adherent, and we have to have a script that works for us. And what I like to do is to ask them, well, it's hard to remember treatment. It's hard to remember. Would you be more likely to forget your morning? When everything's busy getting the kids off to school, or the evening, when you're so tired. Which are you more likely to forget? And they say, oh, look, yeah, sometimes I forget the evening. So, in a normal week, would you miss, 2 or 3, or, maybe 4 or 5? And it slowly comes out, and what
so
you're doing...
give them non-punitive permission.
Yeah, you're giving them permission to fess up, and they want to tell you, and it's critical they do. So we have to have sort of history-taking skills. The other thing is, do they know how to use the device correctly? Okay, because every device can be used correctly and every device can be used incorrectly in a plethora of ways, and we've all seen that. So diagnosis, symptoms related to asthma, adherence in all the different things, and are they actually getting the drug in? And are they well educated? Do they understand what we're trying to achieve? And are they measuring their asthma if that's what we want them to do?
So Clive, how do you cope with that in a busy rural practice where you've obviously got a queue a mile long and out the door and around the corner? To patients to see you, to actually get that level of education. How do you organise that in your practice?
NAC provides some pretty good written literature, action plans, symptom charts, symptom diaries. So those are useful things, but it's also spending that time and trying to develop a relationship with that patient over time, where every time they come, checking their lung function. Every time they come, checking the inhaler technique, finding out what's going on with their symptoms, and then of course using asthma educators, bringing extra people.
Even in rural towns, you'll find asthma.
Absolutely.
To what extent have we got them around the country, Judy?
Well, they are dotted around all over Australia. There's now a national association for asthma and respiratory educators, which is really encouraging for the profession. Having said that, there's still difficulty in accessing them as well, and I know that happens.
So take us through the action plans and just remind us how they're working.
Action plans are very useful tools. I think there's something that needs to be considered prior to even writing up an action plan, is understanding that patients understand their medications. If you're going to use peak flows on their action plans, they do have to have recorded their peak flow for about 2 weeks when they're well, to ascertain what the patient's best is when they're well. And I think that's really important to mention prior to using that on an action plan. It's not based on a one-off peak expiratory flow measurement.
So if you start somebody when they're sick, you've got to kind of catch up.
That's right, exactly, and coming back for review. Written asthma action plans, the uptake of them out there in the population, the last study was 23%. So they're, for people with asthma, a lot of people don't have them. They're a very useful tool in recognising deterioration of their asthma, and then more importantly, what steps patients can make to manage their asthma at home without having to rush to the doctors. There's a lot of self-management skills here. We've got the different areas, so that's when they're well, when they're not so well, and when to seek medical help. There's a variety of performers available. Some pharmaceutical companies provide them for us. The National Asthma Council has them on their website. There's some picture ones and coloured ones. There's also some culturally relevant ones for Aboriginal Torres Strait communities. And more recently, there's the Symbicort maintenance and reliever therapy action plan as well. So that is very easy tick box and provides simple instructions about how patients can manage their asthma when they're using Symbicort as a maintenance and reliever therapy.
Good. Any comments on use of asthma action plans, Matthew?
Oh, I was one of the key developers for the Symbicort Smart Action Plan. I think it's absolutely brilliant. But look, I think action plans are important. We have proven in our healthcare system, as much as we think they're important, we haven't delivered them, so we have a structural problem. And we haven't been able to convince ourselves and our patients of their merits in a way that actually rolls them out. I'm actually very hopeful for the Symbicort Smart Action Plan because I think it's simple. I think it helps practitioners at all levels to give the education and the action plan, and my experience is it actually works for patients and they're not threatened by it.
So this is AstraZeneca's product, and they're the sponsor of tonight's programme. I mean, is there no place for Seretide anymore?
No, there is a place for Seretide because there is a place both for Symbicort as maintenance treatment and some people, and for Seretide as maintenance treatment. And some people will, on a low dose of Seretide or a low dose of Symbicort, have abolition of their symptoms, no reliever use, no exacerbations. Don't worry, these are great treatments. Walk back to 30 years, everyone's laughing. So there is a place for it. However, we also recognise that there's a group of people who do have rumbling symptoms, who are at risk of exacerbations, whose symptoms fluctuate from month to month or year to year even. And it seems that group of moderate and worse asthma seem to do selectively very well with a product that happens to be produced by AstraZeneca. And that's just the reality, and this is where the evidence is.
Where does the treatment of allergic rhinitis fit into this? Because some people would say that these people who have the rumbling asthma actually have undertreated allergic rhinitis, and if you treat that, you actually can get away from the reliever need. Okay,
there are two very good reasons for treating allergic rhinitis. One is it's an unrecognised, perhaps unacknowledged cause of morbidity in these patients. You know, it really does compromise quality of life having severe allergic rhinitis. And secondly, possibly because the lymphocyte pool recirculates between sinus and chest, improving allergic rhinitis actually improves asthma. So for both those reasons, having a structured approach to allergic rhinitis, from allergen avoidance through saline washes, through nasal steroids for relevant people, is very important.
And that could be started when you're initiating even just the inhaled corticosteroid therapy. Start the allergic rhinitis.
I think we recognise, and Clive would know it. You know, you're getting to the last minute or your last minute of the time you feel you can comfortably allocate to a patient, and there's a waiting room full of patients. But I think anybody with troublesome asthma, we ought to be asking about rhinitis, trying to identify it on the front foot, and treating it for all those good reasons.
Matthew, you know, I think you'd agree that there's no better salesman than a satisfied patient. And patients, when they suddenly are feeling better, they're very happy to come back in whenever they need to for follow-up. And once they're doing well, they'll pretty much, once they're feeling better, they will be more compliant, they will have fewer exacerbations, and they will try some of the different things that you suggest, like trying to manage their allergic rhinitis, like trying to manage some of the issues, trying to get rid of the smokers out the house, you know, controlling dust in environments. That all makes a difference.
Let's go to our next case study. Jan is 35 and a single mother. She has long-standing asthma and is treated with inhaled corticosteroids. She has never had a treatment plan or an action plan. She's clearly not a patient of Clive's yet, and has become progressively unwell over the last 2 months and was admitted to the local hospital after suffering her first acute exacerbation requiring hospitalisation. She was given oral steroids, discharged the following day to be followed up by her GP. She doesn't go back to her GP because she thinks that she should have an asthma action plan, so she comes to Clive a week later telling him she hasn't felt this great in years. So she just got a steroid high here. And,
well, I was going to ask you, is she still on a steroid high, or is she genuinely better controlled? But Jan also, like the previous case, she's also shown, on history, we told that she's exacerbated gradually over time. And again, her therapy needs to be, we need to look at it again. Is inhaled corticosteroid alone sufficient for her? And I would contend that it's probably not. We also need to...
What if you found out she wasn't taking it?
I was just about to go into that. We also need to find out, has she been compliant? How is she using the medication? We've said all these things before, but we can't emphasise it enough. And then again, can she afford the drugs? She says she's a single mum, she's struggling. Is it a priority? Is she actually remembering them? So there's a whole lot of reasons. And are there other features that may have caused her to exacerbate? Has she had respiratory infection? And then once we've established that many of those things in place, then we've got to start with a new asthma plan where we actually got to talk to her, say, well, what would you like to do? How would you like us to, how can we actually help you control your symptoms better, and then find something that works for her.
Judy?
So I'm interested to think that she had actually been well controlled on inhaled corticosteroids, and it's interesting that over just a period of a couple of months that she's declined. So I would certainly be wanting to check her device use and check her adherence to the medications if this is suddenly over the preceding two months it's been declining, which is, you just wonder what's causing
in her
that.
life happening.
Exactly. There could be some increasing stress in her life. Who knows? She might have moved house. She might have got a pet. There could be a whole range of other things that I think we need to look at.
Is this somebody who needs to be seen by a respiratory physician, Matthew?
Oh no, I think that a GP who's interested in asthma with a good structure of care can do this. I mean, the one other point that I'd want to bring up is smoking. We've talked about already, I have the line when I'm in educational sessions that somebody who's queuing up for this new way of treating asthma, who's a smoker, is in the wrong queue. Smoking makes asthma worse, and smoking compromises the response to asthma treatments, whether that's inhaled steroids or oral. So identifying other things that are making things worse are important. No, I don't believe these things these patients all need to be managed by respiratory physicians. But I would say one important thing to Jan that she needs to recognise and needs to know is that she has the potential to have a severe asthma attack. And this is an important part of her.
She's declared herself at risk.
She has declared herself at risk, and there's nothing that predicts future risk more than having had the event in the past. And we need to gently remind her that if there were things that went awry, like adherence, like getting poor technique or something, if they go wrong in the future, she's at risk of having another bad event, and we need to have that, and another reason for having an appropriate action plan to deal with these things earlier before they end up with her in hospital, which contradicts my Mars bar therapy because she's away from work.
Which is from a general practitioner in Queensland. When writing an asthma action plan for a patient, should they double their dose of combination therapy or inhaled corticosteroids if their symptoms deteriorate?
Ian Ross MacDonald published a pretty good paper not a couple of years ago demonstrating that was ineffective, and that patient would probably be better off managed on other therapy, and I think combination therapy would probably suit them well.
But if they're on combination therapy, should the action plan say double it? Judy?
I think patients need to be encouraged to use that. You want something quick acting. The Symbicort maintenance and reliever therapy is quite different, but if they're on standard maintenance therapy, I think the key to deterioration of symptoms is short-acting beta agonists, and use more of it and use it more frequently.
And follow the action plan about when to go back and see your GP.
Exactly.
Yeah, if it's not working,
the critical thing.
if it's not lasting the 3 hours, and that's the time when they should be going back to the GP. That's the short-acting beta agonist that go back to GP.
Clive, let's go back to Jan. What are you going to do for her then, treatment-wise? Assuming that it is an acute exacerbation of asthma, she's been taking her medications reasonably well, and she's motivated.
Look, I think Jan, in the position she finds herself with her scenario, single mum, I think single inhaler therapy is really appealing. And I think putting on a maintenance dose of Symbicort, 200 milligrams twice a day, and then using it as reliever therapy with, if one looks at the action plan, which the pharmaceutical company actually hands out to GPs, and if you haven't got it, you can get it from AstraZeneca. It is well shown that she will do. I think she will do better. And also their guidelines to say if you're using X amount, your action plan between you and the patient, and the action plan itself will say if you're using up to 10 doses a day, you need to see your doctor. You need to seek medical advice. And that way, by reviewing her in a few weeks' time, 3 weeks is probably a good time, we can actually see, we can either up-titrate or down-titrate her medication.
Matthew?
Yeah, look, I think she, as long as she doesn't have major inhaler technique problems, does fit the bill. She has symptoms which are unsatisfactory. She's on an inhaled steroid. She would have found her way into any one of a number of studies that explored the efficacy of Symbicort as both maintenance and reliever treatment, and it outperformed every other comparator. So I think she's an excellent, I agree with, she's an excellent patient. I agree that I would use 206 twice daily and as needed, and I would definitely use it in conjunction with an asthma, with the Symbicort Smart Action Plan. Not just because I wrote it, because everybody should have an action plan, particularly once you've had a bad exacerbation. I think, and the other thing about the action plan, it has been externally reviewed and endorsed by the National Asthma Council. It's available from the National Asthma Council website, and I've been in other countries and shown it to them, and internationally it's recognised as being very useful and a great thing to come out of Australia, not just me, but lots of other people's efforts into that.
Let's go on to our final case study. It's David. David's lived with asthma for most of his adult life. He also has significant heart failure and gastroesophageal reflux. His current asthma treatment includes fluticasone, 1,000 micrograms a day, and salbutamol as required for relief, and he's taking that about 2 or 3 times a week. Following increasing breathlessness, he switched to formoterol. Despite increasing doses, he's showing no improvement. Clive.
The way this scenario has been written, I think the first thing
It's a true story.
Oh, yeah, of course, yes. But the first thing that screams at me, have we got the correct diagnosis? Yes, he may well have had asthma for much of his life, but is the reason for his current exacerbation, is it related not perhaps to his cardiac failure? Is it not perhaps related to some other respiratory disease? Or is it has something suddenly gone with his
reflux, presumably.
Or possibly his reflux could also worsen his bronchospasm. But is he not perhaps on new drugs like a beta blocker, or is he using the medication that his asthma medication either correctly, or is he actually using it at all? So that begs a whole lot of questions, and I think we probably need to firstly get a better history and have a pretty good look at him.
So Matthew, if he isn't a beta blocker, I thought it was a bit of mythology here that GPs have been too nervous about putting patients on beta blockers for cardiac failure, and it's a life-saving drug.
If we go away from asthma to COPD to start with, I think there should be very limited concerns about using beta blockers in people with heart failure and concomitant COPD.
In other words, use it.
Because the heart failure benefits are so profound. That having been said, the heart failure studies systematically excluded people with asthma. So we don't have information about the people who get pronounced bronchoconstriction in response to beta blocker, whether in fact they're tablets or even timolol eye drops, which can do the same thing. So if you have spectacular bronchoconstriction with beta blocker, then unfortunately we have to go to less than ideal current heart failure treatment. But when you see an abrupt change in apparently stable asthma, then all sorts of things, including drugs, need to be considered.
So there's really no halfway point, is there? As in a small effect to beta blockers onto...
It's a very interesting, because we see these people from time to time. This beta blocker-induced airway narrowing is a very interesting symptom, and where I've seen most problems is actually not in people who've had lifelong recognised asthma, but this just causes that. They must be just peculiarly requiring their adrenergic systems to keep their airways patent. So it hasn't been the guy who's had lifelong asthma who's then got heart failure and got wheezy when he's on beta blocker.
Do you do provocation tests with beta blockers ever?
No. Oh, no, sorry. Yes, I do. And what we tend to do is a high-risk patient, heart failure, stabilising in hospital, give them a short-acting beta blocker and monitor their lung function for a few hours. If they tolerate that, then go on with the standard twice-a-day treatment.
Can you get somebody where it is the beta blocker, but after they've been on the beta blocker for a while? In other words, it doesn't come on at the beginning of beta blocker therapy, but during it, and it is the beta blocker.
The ones that I'm concerned about, it's pretty obvious. It happens pretty quickly, and it's generally pretty, it's reasonably clear observation. Yeah.
So disentangling this person with breathlessness must be hard, Matthew.
Oh, breathlessness is a wonderful symptom.
Keeps respiratory physicians in,
keeps
meat on the
everybody
table
in
for
work.
life.
And what do you need to exercise? We need a structure. You need hearts that pump more blood, lungs that move more air. The air and the blood needs to meet in the lungs. We need enough hemoglobin to carry it around. We need strong muscles to do the task. The task can't be overly heavy, and we need to respond normally in terms of brain responses to the symptoms of exercise. And any of those things going wrong will lead to symptom of breathlessness. So here, is it heart failure? Has he gained weight? Has he had a sequence of illnesses that have led to deconditioning and he's now unfit and wants to go back to what he used to do? Or is it asthma? And of course, the important thing about knowing if it's asthma is that we have new avenues of treating him that will improve him. And if we get his oxygenation, his airway function better, his heart failure will improve.
But if you jump to that assumption too early, you're asking for disappointment.
I think, we're selling the guy short. And this is why some of the complex care items that have been rolled out into general practice, this is a perfect case where integrated care at all levels with all clinicians involved is critical to improve the outcomes for patients like this in our community.
And just by way of a promo, the National Asthma Council Australia's next programme for the Rural Health Education Foundation will be on breathlessness in the older adult. Is it asthma? And that will be on in September of this year. So what are your takeaway messages for people watching, Judy?
I think one of the things for patients and health practitioners is to work together. It's a team approach to care. It's a chronic condition. Requires ongoing review, especially when the patient is well, to ascertain whether they are on the appropriate medication and still maintaining good control. I think one of the other key things is device use, ensuring that patients using their devices correctly, and that's one of the key things. I think we've all talked about that this evening. So using their device correctly and having it checked regularly, not just asking the patient how are you going with your device, but actually physically getting them to show you how you're using it.
And how do you know the GP knows how to use it?
Very good point. That is a very good point, and it's a challenge to all of us as health professionals who are working with patients with respiratory conditions to really make an effort to learn and follow the manufacturer's instructions and gain information. And pharmacists are a wonderful ally in that. They're the first port of call when patients get their medications, and I know that there's a lot of training for pharmacists in asthma management as we speak. Yeah. We're seeing that through our the NAC Asthma A-Team education programs, getting a lot of pharmacists attending those to update.
Stephen, takeaway messages.
Yeah, exactly. I mean, anyone who walks out of the pharmacy with an inhaler and hasn't had instruction, really, the pharmacist hasn't done their job. There's always time to give someone with an inhaler instructions. Otherwise, you're really sending someone away with very expensive medication and no instructions, and they will get it wrong. Take-home message, let's have a look at inhaled steroids and long-acting beta agonists and combination therapy. Let's have a look at some of the dispensing records and just find out how are people taking it, and let's talk to people about when they're taking it, how often they're taking it, and some of the issues surrounding that, so we can start.
So a stepwise approach. Don't jump to combination therapy.
So we can start to get some more compliance and adherence, and some of these other issues that exactly more important before you jump to a higher dose and other issues like that.
Clive?
Keeping it simple. We need to get our patients involved and responsible for their own management. Empowering with the fact that they can be well controlled. Simple methods, getting them to do the simple things properly. We just follow them, and also follow-up is just finding out that the patient is maintaining their control. And if they're not, we need to adjust their medication appropriately.
Matthew?
Yeah, I think that clinicians should be confident to just use inhaled steroids in mild asthma, and when they're getting moderate or severe asthma, then use a combination treatment. If you haven't experimented in your patients with the use of Symbicort as maintenance and reliever, have a go, have a look at the action plan, and particularly if you're one who's abandoned action plans, it's just too complicated, just too hard, then have a go and just try it again. And I think you'll actually find that it's a good way to improve outcomes for these patients who have really quite significant ongoing needs.
Well, thank you all very much. I hope you've enjoyed tonight's programme. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website. And that, as always, is at rhef.com.au. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Thanks to the National Asthma Council for making the programme possible, and to AstraZeneca, who funded the programme through an Untitled Educational Grant. And of course to you for taking the time to attend and contribute. I'm Norman Swan. Bye for now.